Good morning, everyone. We will be starting at sharp 10 o'clock. Thank you for your patience, and we'll see you in a bit. And emerging. I'm pleased to announce that today's session will focus on neurology and nephrology, with two distinguished speakers sharing their expertise and insights with us. Our first speaker, just in front of us, is Dr. Ramesh Sahathevan, a consultant neurologist based in Ballarat with a special interest in stroke prevention and care. He will be discussing the clinical features, pathophysiology, and diagnostic criteria for idiopathic Parkinson's disease. Our second speaker, who will be later on in about 1.5 hours from now, is the Associate Professor Dr. Sree Krishna Venuthurupalli, a highly qualified renal physician with more than 25 years of experience in the field of nephrology. Dr. Sree has an extensive research profile, having published in national and international journals and presented at major conferences both locally and abroad. He will be sharing his insights on chronic kidney disease progression and diabetic kidney disease in primary care. In addition to these insightful talks, we also have incorporated a performance review before and after each session. So to ensure you receive your CPD hours, a QR code will be displayed for the audience to scan from their phones and link for the desktop as well as to provide. There will be two performance review activities during the session. One is before each speaker's presentation and one after. Each review activity will take about 10 to 15 minutes. You will be allotted 10 to 15 minutes, and you're free to ask any questions if you have during those times as well. And this is an opportunity for you to provide any feedback if you have on the session and receive your CPD certificate after. These reviews are an essential part of the CPD program and are designed to help you earn your reviewing performance CPD hours. After each review, we will also continue with the speaker's presentation, and which will also include a lot of polls. So if you have any questions, you can feel free to ask in between that. We have a fantastic program lined up for today, and I hope you'll find both informative and engaging. Thank you for joining us today, and I will just share the performance review link so you can join from the desktop, and I'll share my screen for the QR code for you to scan. Is this visible, Dr. Ramesh?
Nazia, can you hear me?
Yes, I can.
Nazia, there's feedback from one of the participants about an echo.
From my end, was it?
I think so.
Okay. I will try to fix this and mute myself for now. Is this better, Dr. Imelda? Has the echo disappeared, or is it only with my microphone which happens? I can just mute myself and turn off my video for another 10 more minutes. We'll give ample of time for everyone to answer their questions. Dr. Ramesh, if you'd like to go off camera, that's fine as well. Or else we do have questions coming in, so it's all good. Dr. Sharif and Dr. Sujiva, we are waiting for a performance review. That is within the start of the presentation by Dr. Ramesh. So we'll just request you to fill out the form. That is for the performance review CPD hours. And once that is done, in about 3 or 4 minutes, we shall start with the activity. And that is why you can't hear this. Are you able to see it, Dr. Vajira? There is a QR code which you can scan now. Thank you. Dr. Emil, thank you so much. It should be the same one, and this should have a couple of questions. This is the same one which is shared in the link of the chat with everyone. Dr. Hussain, we've actually blocked out our videos, but now I've restarted it again for any confusion. So please let us know if you have any questions. Whichever doctor is just mentioning about a question that you cannot access the chat link of your phone, you can use the Q&A model also if you have any issues. But if it is about the questionnaire, the snap form, just leave me a message on gp@telecare.com.au, and then we can definitely give you the questions again. Dr. Mashal, yes, this is to be done before the session. So the session will actually cover all of these questions, and the same questions will be repeated after. So this is a reviewing performance of how much you have learned or how beneficial it was, how informative it was. Dr. Hussain, in about less than 5 minutes, we will be starting. Thank you so much. Dr. Ramesh, whenever you're ready.
Nazia, can you see and hear me clearly?
Yes, Dr. Ramesh.
If you're happy for me to start, then.
Yes, please. Thank you.
Thanks, Nazia. Morning, everyone. Thanks for joining us. My name is Ramesh Sahathevan. I'm a neurologist. I'm based out of Ballarat in Victoria. I'd like to thank the organizers, Telecare. I'd like to thank Nazia, especially, who's done a lot to making this a reality, and excuse me, for inviting me to share some of my musings. It's always a privilege and an honor to speak to your colleagues. I'd like to start by acknowledging the traditional custodians of the land from which I am speaking today. I'd like to pay my respects to their elders, past and present. I'd also like to extend my respects to any Aboriginal and Torres Strait Islanders who are attending today's talk. My disclosures, first and foremost, I am one of the neurologists who offers consultations through Telecare. The second is that the slides that I've used in this presentation are entirely from a website run by the Lundbeck Neuratorium. I'm a member of the Lundbeck Foundation, and we are the ones who have sort of helped to develop these slides as well. If any of you are interested, this is the website. I'd encourage you to visit it. It's quite an interesting collection of slides and topics that you can actually use for free. All you need to do is register. So what are the learning objectives? I'm hoping by the end of this session, I'm able to provide you with a clearer understanding of an approach to the diagnosis and management of idiopathic Parkinson's disease. Spend a little time on the prodromal symptoms of idiopathic Parkinson's disease, moving on to pharmacological and non-pharmacological management of IPD. So as an outline, what I'd like to talk to you about very briefly today, the background and history of idiopathic Parkinson's disease, epidemiology of the disease, what are your clinical presentations, what are these prodromal symptoms that I think many of you probably sort of heard of because of growing interest, both in the popular press and amongst our patients. What are the pharmacological therapies that are available, and also non-pharmacological options. In 1817, an English surgeon and apothecary by the name of James Parkinson published this essay. and he called it the shaking palsy. Now, the fun thing about preparing a talk is that you actually learn yourself. And what I learned was that I'd always thought that the 6 patients that he described in this essay were people that he had simply observed walking the streets of London. I was wrong. So while 3 of the patients were based on observation, 3 of the patients were actually his patients whom he had the privilege or the ability to examine. So he describes this involuntary tremulous motion with lessened muscle power, in parts not in action and therefore at rest, and that there was a propensity for them to bend the trunk forward and pass from a walking to a running pace. And that's something that I think a lot of you have seen in your patients. Further on, he says that in this stage, sleep becomes much disturbed. The bowels, which have all along been torpid, now in most cases, demand stimulating medicines of considerable power, speaking therefore of constipation. And he goes on to say that in certain cases, patients require manual removal of feces. What James Parkinson wrote in 1817 sort of remained within the medical literature. As more interest grew, the eminent French neurologist Charcot spoke of this and felt that it was time to rename the condition, not the shaking palsy or paralysis agitans as James Parkinson's had himself described it, but instead that it would be called Parkinson's disease. And I think even then there was an idea or an argument going on in terms of whether there was actually a form of neurosis. And I think when they found that there were actually brain changes on autopsy, that it was diagnosed as being sort of a neurological or neurodegenerative condition. In 1895, excuse me, another French neurologist marked the area of the brain in which the changes occur as being the substantia nigra. How much of a burden is Parkinson's disease? And here I'd like to talk to you about the epidemiology of disease. So firstly, Parkinson's is the second most common neurodegenerative condition after dementia as a whole. There are 6 million people living with Parkinson's disease worldwide, and this affects roughly 1 to 2 people per 1,000 population. As patients get older, the risk, unfortunately, of Parkinson's increases as well. So if you're looking at about the age of 60, the prevalence of Parkinson's is probably about 1%, but as patients reach into their 80s or more, that prevalence increases to 4 to, or maybe even up to 10%. Is there a change associated with age? And as I said, yes. Unfortunately, as people get older, the risk of having Parkinson's increases as well. This table demonstrates, or rather, the authors have described that the prevalence of Parkinson's is perhaps not as high in Asia, but I think that that's actually, unfortunately, weakness on our part, because that data was probably not available. And you will see for yourself that unfortunately Africa is not represented in this table for the same reason. Are men and women equally affected? And unfortunately, no, for those of us who are male, being male offers an increased risk of Parkinson's. With all neurodegenerative conditions, with all neurological conditions generally, there's unfortunately a high dollar value. The total cost of Parkinson's is considered to be 23 billion per year, and this is in the US. The Americans have very good data regarding cost of disease because of their medical insurance structure. Where does most of this cost come from? It comes from loss of productivity attributed to those people with Parkinson's not being able to work. What is the interplay then between why some people get Parkinson's and some don't? So risk factors that are associated would be things like age, sex, is there genetics involved, is there family history, things like pesticide exposure, heavy metal exposure, previous traumatic brain injury. And then, of course, there are the so-called protective factors, such as smoking or caffeine. Smoking, as always, is always a very contentious thing. And I think that what I'm going to say is there's probably an attrition effect that makes it seem like smoking might be a protective factor. The proponents for this say that it has to do with nicotine neurotransmission as well. But look, I'd probably say that at this stage, it's kind of open for discussion. Why then is it that some people develop Parkinson's? And I said, it seems to be an interplay between what your predisposing factors are, such as your genetics, the environment, rural living, where you might be more prone to exposure from heavy metals in well water, or if you use pesticides. MPTP is actually a synthetic heroin derivative, and that was one of the things that was associated with Parkinson's in the 1980s. These things are meant to then come together and start off the sort of pathogenesis of Parkinson's that ultimately leads to cell death within the substantia nigra. What are your clinical presentations? And this is something that all of you know. The general term Parkinsonism is when we find a patient demonstrating signs of Parkinson's disease, and the four cardinal features of Parkinsonism are bradykinesia, muscle rigidity, resting tremor, and postural instability with gait impairment or without. Now, these features are not seen in every patient and not seen together at any given time. What are these features? Bradykinesia is slowness of movement. If you have akinesia, you have absolute lack of movement. If you have hypokinesia, there's a slight reduction or poverty of movement. And this is the defining feature of Parkinson's disease, not tremor. Tremor is perhaps the most visible form, and tremor is what most of our patients associate with Parkinson's. But the defining feature of Parkinson's is bradykinesia. What I usually tell my colleagues who are training to be physicians is that if you think about it, the tremor of Parkinson's is tremor, the rigidity of Parkinson's is rigidity. But when you examine a patient, practically everything else is a manifestation of bradykinesia, including things like decreased facial expression and blinking, the soft voice, the difficulty of swallowing, the micrographia or small writing, which is demonstrated here. Rigidity is resistance to movement. And there are two forms of rigidity which we see: cogwheeling rigidity, which is generally demonstrated at the wrist, or lead pipe rigidity, which is demonstrated on examination of the elbow joint. Now, this rigidity can affect any part of the body, the neck, the arms, the leg, and if it affects the back, it leads to your typical sort of Parkinsonian appearance of the stoop. Patients complain of turning in bed or rising from a chair as a manifestation of this rigidity as well. Tremor is generally a resting tremor, and this is described as rhythmic, oscillatory, involuntary movement that comes about when the affected body part is relaxed and supported by a surface. So this kind of makes sense because your patients will come to you saying that, look, if I leave my hand on the table, I suddenly notice that it starts to shake. If I put my hand on the armrest, if I rest my hand on my thigh, that's when they see the tremor. The pill rolling tremor, again, is something that all of you are familiar with, and it's basically that sort of movement. The tremor of Parkinson's is relieved by purposeful active movement. So I stress again, it is a tremor at rest. It is generally asymmetric. You'll find that patients come to you telling you that I've noticed a tremor in one hand. Now, I was saying to you earlier that the tremor of Parkinson's is the most noticeable feature, especially amongst the public. And I remind you that that's what Parkinson's disease was initially called, the shaking palsy. It's present in about 70% of patients, but tremor may not occur in about 20, 30% of patients. The other thing that is seen is postural instability, and this is thought to be the fourth cardinal feature of Parkinson's disease. What happens in postural instability? Your patients have the stooped posture that I spoke of as a result of rigidity, and because of this, their ability to right themselves if they come to an obstacle or if they trip or if unfortunately someone sort of pushes them from the back is lost. And this unfortunately is what leads to the increased risk of falls and falling seen in patients with Parkinson's disease. Thankfully, this is something that is seen late in the disease. If you find that your patients have postural instability very early on in the disease state, it suggests that there might be something else going on. The symptoms of Parkinson's, as I said, have to do with the cardinal features as I spoke of earlier. Bradykinesia, rigidity, tremor, postural instability. In the last 20 years or so, there has also been interest in all of these non-motor symptoms of Parkinson's disease. And here, having divided it up into autonomic, sleep, neuropsychiatric, and sensory disturbances, you see that there is a vast array of symptoms that patients might develop. They might complain of dribbling of saliva, dysphagia, constipation, urinary issues, sexual dysfunction, orthostatic hypotension, which can occur in idiopathic Parkinson's disease fairly early on as a result of the medication that we use to treat, or as part of other Parkinsonian-like features. Sleep becomes an issue. Patients might complain of either insomnia or excessive daytime sleepiness. And during sleep, they experience vivid dreams or REM sleep behavior disorders, which can affect their partner. Neuropsychiatric conditions such as cognitive impairment, mood disorders tend to occur a little later on in the course of disease, alongside things like hallucinations and delusions. Impulsive compulsive behavior, is normally seen either as part of a Parkinson's-like condition or as a result of treatment with certain agents. Patients with Parkinson's might have olfactory, visual, auditory dysfunction. And this is because we know that one, and I'll speak of this later, while the dopamine neurotransmitter is the one that is most commonly affected, other neurotransmitters can also start to deplete. And while dopamine neurotransmitter is mostly used in the motor pathways, being the most common neurotransmitter in the brain, it also subserves other neurological parts or other neurological functions, I should say. So what do we do in terms of staging of the disease? How do we think to ourselves that our patients are mild, moderate, or severe? And there's something called the Hearn and Yahr score. If our patient falls within the 1 to 2, it suggests that their movements or their symptoms may be inconvenient, but it doesn't really impair them on a day-to-day. The symptoms are still unilateral. And friends or family might notice that, look, there's something not quite right because you don't seem to be smiling as much. When you talk, it's much softer than it used to be before. At this stage of the disease, you can either use medication or you can say, look, I think you've got Parkinson's disease, but perhaps we don't have to rush in to treat it right now. We can watch and see. At this stage, exercise is a very important part because it helps to maintain mobility and flexibility. In stage 3, the symptoms have now moved to involve both sides of the body, but I'd like to stress here to all of you that Parkinson's is actually a unilateral disease. So it starts on the one side of the body. Over the years, it will spread to the other side, but it always remains more apparent both to you when you examine and to the patient on the side on which it started. At this stage, the patient begins to develop issues with balance and coordination, and there might be freezing episodes. What is that? That is when your patient tells you, look, I was walking across the room, or I was walking after I got up from the chair to go into the kitchen, and suddenly my feet felt as if they were glued to the ground. At this stage, patients who are on treatment might start to tell you, my medication doesn't seem to be as effective as it was before. I feel that the positive effect that I saw before seems to be much shorter. And sometimes I get these funny sorts of movement, I should say. Sometimes the medication just suddenly wears off. I'll come to what these terms actually mean a little later on. In stage 4 or 5, the patients are now severely impaired. They require help, supervision for activities of daily living. They may not be able to live on their own anymore. In patients with stage 5 disease, they might either be in a wheelchair, perhaps even at times bedbound. At this stage, issues like cognition or behavioral problems are more prominent, including things like hallucinosis. When you reach this stage, in terms of treatment, it is a question of finding a balance between the positive effect of the medication and the possible adverse or side effects, including things like dyskinesia. How do we then say, okay, how can I stage my patient? Can I just go on this sort of 1 to 2 being this, 3 being this, 4 to 5 being the other? And there is a way that we use, and it's called the UPDRS. MDS stands for the Movement Disorder Society. This is sort of a questionnaire that can be used to determine how badly your patient is affected. It's used mostly by neurologists who have an interest or are only treating patients with Parkinson's. The issue with coming to a diagnosis of idiopathic Parkinson's disease is that there's unfortunately no definitive blood test or imaging study that we can use, as all of you well know. So how do we come to a diagnosis? We are still making our diagnosis on clinical grounds. So therefore, if you have someone who presents with Parkinsonism, your thought process is this idiopathic Parkinson's disease, or is this something else? And the something else includes secondary Parkinsonism or Parkinsonism, which is part of some other neurodegenerative condition, such as multisystem atrophy, progressive supranuclear palsy. At times, you also have to differentiate whether your patient actually has Parkinsonism. And this is where things like the appreciation of the tremor come in. The commonest form of tremor remains something called essential tremor. It's 10 times more common than Parkinson's disease. And the hallmark of essential tremor, bilateral, it can occur at any age. Patients will tell you that the more I try and do something, the more my hand shakes. Examples would be eating and drinking. I'm using my knife and fork. The more I bring my fork to my mouth, the more it shakes. The more I lift my cup to my mouth, the more it shakes. These tremors are typically worse if a patient's anxious or annoyed. And the hallmark, of course, as I think all of you would know, is that it improves with alcohol, but not in everyone. When you're dealing with someone with Parkinson's or Parkinsonism, this ability to sort of differentiate in the early parts of the disease can be a bit of a problem. But it's a question, I think, of just going back to the history, going back to your physical exam, and making sure that almost at every visit, you're reassessing your patient, because that's exactly what I do. Secondary Parkinsonism is when the Parkinson's is due to something else. So this dopamine depletion is being caused by some other insult. Encephalitis lethargica is, I think, more historical context, because this was seen in patients who survived the Spanish influenza outbreak in the early 1900s. Those of you who are sort of paying attention to what's going on with the current pandemic will say, look, Ramesh, do you think that there's a chance that long COVID may be associated with an increased risk of Parkinson's? And honestly, at this stage, I can't tell you. The interesting thing, of course, is that patients with COVID, if you remember in the early days when it was still sort of, what is this about? What are your most common presenting factors? Most of you will remember the loss of sense of smell. And that's supposed to be one of the prodromal things seen in Parkinson's. The other things that are associated with secondary Parkinsonism include things like carbon monoxide poisoning, drugs such as dopamine antagonists, and this includes your antipsychotics, whether it's the older ones like haloperidol or the newer ones. The difference being that with the older one, the onset is usually quite quick. With the newer ones, it might take a few years, but unfortunately, there's still a chance, a very high chance, I should say, that it will occur. Conditions of historical interest, like the striatal variant of dementia pugilistica, which is what Muhammad Ali was thought to have, go alongside metabolic conditions like Wilson's disease, which is a copper deposition disorder. There's something called vascular Parkinsonism, where your symptoms appear in the lower limbs, but not so much in the upper. And that has to do with either strokes in certain parts of the brain or patients with significant deep white matter disease. And then you've got the sort of miscellaneous conditions like Huntington's disease, conditions of spinocerebellar atrophy, conditions associated with frontotemporal dementia. The list of secondary Parkinson's is fairly, frankly, it's very extensive. But I think it's just a question of, are your suspicions strong enough to think that your patient has Parkinsonism rather than idiopathic Parkinson's disease? There are, as I said, no definitive blood tests that you can do to prove that someone has idiopathic Parkinson's disease. there are no definitive imaging techniques that are widely available that could do the same. But in certain patients, you might consider asking for an MRI. So this is where you're thinking to yourself, okay, my patient has these features of Parkinson's disease, but I'm not too sure if it fulfills this diagnostic criteria. In these patients, an MRI might be useful because it helps to pick up other conditions. Things like transcranial ultrasonography, things like SPECT are of interest, not widely available, more research, quite expensive. This is an example of a SPECT scan using a radioactive iodine isotope. And what it does is that it shows you the concentration of dopamine within the substantia nigra of the brain. If you find that there's a decrease, if your patient has clinical features that support a diagnosis of idiopathic Parkinson's disease, that might be the reason. The idea of the dopamine deficiency, which I spoke of earlier, which I've alluded to through my talk, has to do with a specific dopamine deficiency within the substantia nigra. And as I was saying, in 1895, this was shown to be the sort of unifying feature in people with Parkinson's disease. When the brain is examined for part of gross pathology, it is found that within the substantia nigra, which is a part of your midbrain structure, there is actually a reduction in the dopamine cells or dopamine production. Substantia nigra basically means black body, and you can actually see that that reduction of blackness or hyperpigmentation is something that can be evaluated with the naked eye. What's causing this change? And this is something called a Lewy body. Lewy bodies are the pathological change that is seen in people with Parkinson's disease. And what is it made up of? It's made up of this thing called alpha-synuclein, which is actually a component of the synapse, but for some unknown reason, in certain people, it begins to aggregate, form fibrils, and these fibrils then come together and form what's known as a Lewy body within the substantia nigra, therefore reducing the effectiveness of how that part of the brain works and depletes dopamine. Ladies and gentlemen, I've spoken to you before this about the sort of clinical presentations of Parkinson's disease. I've given you an idea in terms of what the common clinical features are when a patient walks through your door, what you might need to think of in terms of, is this really idiopathic Parkinson's disease? Is this perhaps something else? And a very rough idea in terms of the pathology. In recent years, there's been a lot of interest in this thing called the prodromal state of Parkinson's disease. What is this about? Where we used to concentrate on these are the clinical features of idiopathic Parkinson's disease, there's now a lot of interest about, can we determine if someone is at risk of developing Parkinson's disease because of symptoms that may not have to do with bradykinesia, increased tone, tremor, or postural instability. And this is where things like anxiety, constipation, excessive daytime sleepiness, a reduction or loss of sense of smell, other mood issues such as depression, and other sleep-related issues such as REM sleep behavior disorder. What we now think is that conditions such as constipation might actually predate the onset of Parkinson's by 20 years. that things like REM sleep disorders might actually predate by perhaps 10 years. That things like hyposmia or loss of sense of smell or reduction of sense of smell might start anywhere from 10 years to actual onset. Now, I think some of you might have heard on the news, I think it was 2 days ago on one of the talk shows. I think the researcher is either from Queensland or New South Wales, and they were talking about the research that they have done into a reduction or loss of sense of smell. These are very interesting things for us to consider, and these are questions that I generally ask my patients because it helps to give me an idea of whether they might actually have Parkinson's disease or something else. Are we now going to go away with this fear that anyone who has constipation is going to develop Parkinson's in about 20 years? Anyone who comes to us with issues of sleep or loss of smell is going to develop Parkinson's in 10 years or 5 years. At this stage, I'm going to say no. It is a growing field of research. We are learning more and more each day, but at this stage, these are things to watch. There is no role for initiating treatment with any of the sort of Parkinson's drugs. So what then are these drugs? What are the medications that we use? The mainstay of Parkinson's, if we're talking about it from a pathological point of view, is that there is depletion of dopamine within the substance nigra, as I've said. What do we then use to treat? We use something that is similar to dopamine. We use levodopa. Levodopa is a compound that is used in the synthesis of various transmitters, neurotransmitters, including dopamine. To prevent levodopa from being converted to dopamine outside the brain, which is when patients develop issues of nausea, vomiting, unsteadiness, it is paired with a peripheral dopa decarboxylase inhibitor. What are these? Dopamine is levodopa, as I said, is the precursor that we give our patients. The most common dopamine decarboxylase inhibitors are carbidopa and benserazide. So if you have levodopa and carbidopa, it's Kinsin or Sinemet. If you have levodopa and benserazide, it's Mardopa. What are the other medications that we use? So instead of using a precursor to dopamine, thus enabling our body to sort of increase its dopamine output, or the brain rather, I should say, we use things that are similar to dopamine. And this is where the dopamine agonists come in, and they work on the same receptors that dopamine would act on. The dopamine agonists, unfortunately, are associated with a very unique set of side effects, which come under what we call impulse control disorders. And this is usually seen in people who might be predisposed. So for instance, if you know that a patient of yours has a problem with addiction, whether that's smoking, whether that's drinking, whether that's pathological gambling, you might be a little wary of giving them this medication. I would not say that it is an absolute contraindication. I would say that you would proceed with caution. Monoamine oxidase inhibitors help with the reduction of dopamine breakdown. And these medications include selegiline, which is one of the older ones, and rizagiline, which is a newer preparation, or Azilect, as some of you might know it. I spoke to you about how we use dopa decarboxylase inhibitors to reduce the breakdown of levodopa, or conversion of levodopa to dopamine, sorry. There are other medications that we use to reduce the effectiveness of COMT, which breaks down levodopa. What are the common COMT inhibitors? Entacapone is one. And again, this is used either as a separate medication in itself or in combination with levodopa, carbidopa, and that's Stalevo. Therefore, just remember that entacapone in itself is useless if it is not combined with levodopa. There are medications that are used for symptomatic management, and this includes things like benzhexol. Now, benzhexol is an anticholinergic, and therefore it's very useful for tremor. What's the problem? You might be a little cautious about using it in older people because of the anticholinergic effect. Patients might suffer from dryness of the mouth. Patients might suffer from urinary retention. If you have an older patient who has cognitive impairment, you would be very cautious about using something like an anticholinergic therapy because it might actually trigger frank psychosis or worsen their cognitive impairment. There are medications that we use, such as amantadine. When do we use amantadine? In patients who have dyskinesias as a result of Parkinson's medications. There are other medications targeting other neurotransmitters, which are currently under investigation. This would include things like serotonin and the rest, but nothing is quite in use in this group of patients. Those of you who are familiar with the treatment of Alzheimer's disease using rivastigmine will know that in patients with Parkinson's disease dementia, there is a role for rivastigmine. Those of you who deal with Parkinson's patients who are unfortunately having issues of psychosis might have used one of the newer antipsychotics to help with that. And we generally use quetiapine rather than any of the others. There's a newer agent called pimavanserin, which I think came on the market about 3 to 4 years ago. When you're dealing with medications in Parkinson's, there are terms that we use. What are these terms? On and off. On basically means that the patient is able to tell you, I take my medication at this time, and within 20 to 30 minutes, I feel it sort of kicking in. Off is therefore the opposite of that the medication is no longer as effective. The off period can occur either as a sort of a gradual, where it starts to wear off as the patient approaches their next dose, or where they have an unpredictable off, where they suddenly lose the effect. And this leads to the freezing episodes that I was speaking of earlier. Dyskinesias are unfortunately very common in patients with Parkinson's disease who are on treatment. This comes in as the patients have been on treatment with dopamine agents for a long period. Patients with dyskinesia have different sort of manifestations. You have an on-period dyskinesia, where it happens sort of in the middle of 2 doses. These are the patients who have sort of funny limb writhing movements that you might see. They have a sort of a cervical dystonia or cervical movement, or they have a funny movement of their arms. It's almost like dancing, which is what choreoathetosis actually comes from. You can have biphasic dyskinesias, where your patient has a dyskinesia just after they've taken their dose and towards the end of their dose when they're going to take their next one. And then you have the off period. So this is when the patient's medications have sort of worn off. And as I said, this can occur in the initial stages, kind of predictably, but in the later stages, unfortunately, unpredictably, and the off-period dystonia is usually seen in the lower limbs and can be very painful. How then do we deal with the patients with advanced stages of dyskinesia? Identification of how the medication effect fluctuates is very important. And from there, we think about using things like transdermal patches, which can also be used earlier. There is a lot of interest in inhaled forms of therapy. And there is also use of percutaneous pumps, where the tubing is threaded directly into the jejunum, and the patient has a gel. This is what deodopa is, that is then infused slowly through the day. What are your non-pharmacological options? Deep brain stimulation, which again, a lot of you would probably be aware of, is where electrodes are placed within specific parts of the basal ganglia. And it helps with patients who have severe dyskinesias as a result of medication, patients who are no longer as responsive, patients who have unpredictable on-offs. There are assessments that need to be done on these patients beforehand. There are, thankfully, in Australia, a number of centers within tertiary hospitals that are available, that rather have the expertise to use these interventions. Throughout a patient's time course of Parkinson's disease, the multidisciplinary approach is very important. And this is where a patient with Parkinson's has the benefit of someone assessing them from a speech and language pathology perspective, a physiotherapy perspective, an occupational therapy perspective, having the social worker come in to determine that they have all of the supports that are required. I generally refer my patients to physiotherapy, occupational therapy, and speech therapy very early on, so that they might benefit from having everyone sort of cast their eye, determining what issues might be impairing their activities of daily living, and putting into place things that would help them. And this then sort of sets the stage for things possibly going wrong down the track. Exercise in Parkinson's disease is, again, a field that is, I think, growing in interest. What I say to my patients is that any form of exercise is good, even if it's a 20-minute walk. And we know that this is to sort of secure the motor pathways and encourage plasticity. Those of you who are aware of it or familiar with it would know of something called the PD Warrior program that's available through certain physiotherapy or gyms or general practices. Here in Ballarat, I refer all of my patients to one of the general practice clinics that has this program on it. Ladies and gentlemen, with that, I'd like to thank you for your attention. I hope that I've been able to provide a little more insight into this intriguing condition of idiopathic Parkinson's disease. And I will also add a disclaimer at this point, as I said, because of the complexities of the condition, we don't always get it right. Patients who see me in person for Parkinson's disease have a slightly longer assessment every 2 years or so that I know that I'm on the right page still. Thank you again.
Thank you, Dr. Ramesh. That was really nice and informative. We do have 2 questions. Now, one was raised by Dr. Sujiva, and they were asking what clinical criteria would help distinguish Parkinson's from other cause for GPs to diagnose.
Go back to the sort of basics that I was talking about. Firstly, what is the mainstay of Parkinson's? The mainstay of Parkinson's is bradykinesia. So examine for bradykinesia based on the things that I was talking about. Does your patient have slowness of movement? Does your patient have paucity of facial expression? Is your patient's speech impaired? Does your patient say that, look, my writing has changed? So all of these would be your clinical manifestations of bradykinesia. Then you look to one or the other, as I said, or more of tremor, rigidity, and postural instability. When do you think something's not quite right? Maybe this isn't idiopathic Parkinson's disease if you don't have bradykinesia. If you seem to have tremor with nothing else, then think essential tremor. And I'd like to tell you that in essential tremor, you can have someone who has really bad shakes, which make you think that this is Parkinson's. But think about what I was saying earlier, that in essential tremor, it tends to be bilateral. It tends to be associated with them doing things, fine motor movements. It tends to be associated with them being a little anxious. There might be a family history. The other things that point you away from Parkinson's disease is if your patient's family says, we're a little worried about behavior. Cognitively, our father or mother is not what they were a year ago. There is a concern, perhaps, with reported visual hallucinations, which points you in the direction of dementia of Lewy body disease, for instance. There is a very significant postural drop in blood pressure associated with an increased risk of falls, which might point you in the direction of multi-system atrophy. Occasionally, you might see that your patient has come to you with what's described as Parkinson's or Parkinsonism, and they have muscle twitches, myoclonus. If you ask, they might say, you know, that hand or that limb doesn't belong to me. And that points you in the direction of corticobasal degeneration.
All right. Thank you. There was another question by Dr. Abbas, and they're asking, is the tremor symmetrical?
In Parkinson's disease, the tremor is generally asymmetrical. So as I was saying, what you might find is that patient comes to you and says, look, my hand starts to shake, but it's only on one side. It's only in my right hand. That is very typical of Parkinson's, of idiopathic Parkinson's disease. And as I said, over the years, the tremor will unfortunately spread to the other side to involve the other hand, but it will always be worse on the side on which it first started.
Right. All good. Thank you so much. Is there any question or queries which any other doctor has? They can, you're free to talk. I'll definitely unmute you if you would like to have any question live. You can raise your hand and I can unmute you from here. Or else, otherwise, I'm happy to share my screen for the post review session. That will be allotted another 10-15 minutes, which will be followed by with the nephrology seminar. Looks like we don't have any other questions as for now. Okay, there's another one.
There is a question.
Yes.
Does early initiation of dopamine therapy increase the risk of long-term treatment failure? And if so, should the use of levodopa therapy be delayed as long as possible? This is a very interesting question. And this is actually based on the concerns in the past that if you initiated dopamine therapy early, what was going to happen was that your patient was going to become resistant to it, and that the patient would be more prone to developing dyskinesias and whatnot. What we now say is that if you have a patient who comes to you with what looks like idiopathic Parkinson's disease, if those symptoms are not interfering with the activities of daily living, You can discuss it with them, come to a mutual agreement that, okay, for now, we don't have to treat you. And this does not have to do with a concern about resistance to dopamine later on. It has to do with, why put your patient on a medication unless they really require it? Once you've started the treatment, it does not mean that your patient is at increased risk of developing sort of resistance to it. I think that idea has sort of like been put to rest. Does initiating therapy early change the cause of the disease? Unfortunately, no, it doesn't. The risk of developing dyskinesia occurs somewhere between 5 and 10 years after starting therapy. And that, unfortunately, is still the pattern that we see. Who develops dyskinesia and who doesn't is still something that we can't answer. So if you're saying to me, okay, look, Ramesh, what would you do? So as I said, initiation of dopamine therapy at the early stages is definitely something that I practice. Do I initiate dopamine therapy on all of my patients? No, I don't. I have a discussion with them and say to them, okay, look, do you want to go on medication at this stage, or do you want to wait? Because you have very minimal symptoms or very minimal disease. And I always reassure them that starting the medication doesn't mean that you're going to be resistant to it in a few years.
Right. Thank you so much. Also, mechanism of rasagiline action.
Yeah, so it's a monoamine oxidase inhibitor. And that is a medication, sorry, that's to do with the breakdown of dopamine.
Right. Thank you. Is there any other question? There's another one by Dr. Mehdi. He says, how long you have to start them on medication until you decide its response? Sorry.
Again, excellent question. A patient's response to dopamine is usually very quick. I tend to be a little more conservative because generally, as I said, Parkinson's is a disease of older people. I generally start my patients on a half dose, so 62.5, whether that is levodopa, carbidopa, Sinemet or Kinsin, levodopa, then cerazide, Mardopa. 62.5 milligrams TDS for a week, and then I increase it by half a tablet per dose per week. So meaning that you do half, half, half for a week, half, half, 1 for a week, half, 1, 1, etc. By the time they come back to see me, which is in about 6 to 8 weeks, they're definitely able to tell me, Ramesh, perfect, thank you very much. Or Ramesh, what the hell have you put me on? There's been no change. If they say, be no change, at the back of my mind, okay, did I get it wrong? Is this actually something else? Or is the dose not high enough? And then I would increase it maybe a little faster, or add on things like long-acting dopamine agents, or something like rasagiline or dopamine agonist.
Another question. Can any of the Parkinson's treatment worsen the symptoms?
Again, very good question. Let's deal with the symptomatic part. So I was saying to you that patients who are troubled, especially by tremor, we use anticholinergic medication, Benzhexol, Artane. That doesn't necessarily worsen the symptoms, but they are prone to the side effects, the anticholinergic effect that I was speaking of. Similarly, if you start a patient on dopamine therapy with a levodopa compound or dopamine agonists, what usually occurs is that they develop side effects that can sometimes mimic the problems that they came in with initially. So they might say, look, I feel a little unsteady on my feet. You give them a dopamine agent and they may come back to you and say, look, I feel even worse on my feet. I feel really nauseous and vertiginous. So that is probably an adverse effect of the medication, which is worsening the patient's symptoms underlying. In terms of, do dopamine therapies, do Parkinson's therapies in themselves make your patient's symptoms worse? Not directly.
Dr. Mato says, thank you. All right. Okay, this is an end to the neurology session, I'm believing. If there's any other question, feel free to put it on the Q&A. And I have just shared a link for the post-session review performance. So feel free to please fill out the form. I will be sharing the QR code as well. Dr. Ramesh, thank you so much. If you'd like to stay, Dr. Matas, it's a great presentation. Thank you. If you'd like to stay online for a couple of more minutes for the few questions which may pop up.
Sure. Absolutely.
Thank you so much. I will be sharing my screen and disappearing from the screen. Thank you. Hi, Dr. Shaheen. There is another way. I have shared a link that is exactly just in the chat. So I'm resharing it again. That is the post-session review performance. And there will be another link which will be shared, which will be on the cloud and available online of the presentation that will be shared with you along with the certificates next week. Thank you. Welcome, Dr. Sree. Good morning. How are you?
Hi, hello, Nazia. Good morning. How are you? Can you hear me?
Yes, I can hear you. Thank you so much for joining us.
I know it's all right. It's my pleasure.
Thank you so much. Likewise. We just have finished the neurology session. So this is a QR code which the doctors have to fill out for the post review performance activity. So give me a couple of minutes and we will introduce you and start with your pre-session activity. And meanwhile, we can have an interaction for sure.
Yeah, that's fine. No worries. Yeah.
Thank you so much. Thank you for your patience. Hi, Dr. Michael. I apologize, I do not remember the resource of the website, but I'll definitely check with Dr. Ramesh and get back to you on this one. I'll take note of all the questions which are still pending or which may be coming up later on. And if something is missed, we will get back to you through an email. Thank you. Once again, thank you so much, Dr. Sree. It's an honor to have you present with us again. Everyone, I'd like to introduce our second speaker for the day, and this is Dr. Associate Professor Dr. Sree Krishna Venuthurupalli. He's a highly qualified renal physician with more than 25 years of experience in the field of nephrology. Dr. Sree has an extensive research profile and having published in national and international journals and presented at major conferences, both locally and abroad. He will be sharing his insights on chronic kidney disease progression and diabetic kidney disease in primary care. And I hope you find the event both informative and engaging. Thank you, Dr. Sree. Now, with your permission, I will be sharing a pre-session of your activity that will be a preview of the activities, questions that everyone needs to fill out. It will be another QR code. So we will be allotting around 10 minutes for this activity. So if anyone has a question before this is shared, please feel free to ask Dr. Sree. He's right here. Or else we'll just be on mute and available for any queries that you may have. Thank you
Thanks,
so
Nazia.
much.
Thank you.
No worries, Dr. Sree. Thank you. Good morning, Dr. Inia. Yes, there will be a link and you can listen to the webinar again. We will be sharing it along with your certificates. It will be an online link, so you don't have to install anything. But it will be available online. As I mentioned, it will be with your certificates. Thank you.
All right. Good morning, everyone. Is it, Nazia, is it time to start?
Absolutely, yes, whenever you are ready, Dr. Sree.
Excellent. Thank you. Thanks, everybody. On a Saturday, not easy to join with all the family commitments and other things. Really appreciate your interest, and I hope you find this session useful. And in the background, if you hear our dog barking, please excuse me. She wants to join the webinar too. So that's a problem. So I just put her outside the room. Nazia has a very generous introduction of mine. So I currently work as a nephrologist in Westmorton, that is Ipswich Hospital in Queensland, and I'm an associate professor with the Faculty of Medicine, University of Queensland. And yeah, definitely CKD is my passion. So that's where whenever I get an opportunity to share my knowledge and interact with practitioners and healthcare professionals, I love to talk about CKD. So how do I go shift the slides, Nazia?
You can prompt me because I'm sharing my screen, so I'm happy to do so.
Yeah, that's good. And these are my disclosures. So it's the educational and conference grants from L. Lilly or the Boehringer Ingelheim and the AstraZeneca, please. Yep, next slide. Okay, so the story of kidney disease as an entity. So it well started in 1827. So before that, I don't think kidney disease as such existed as a kidney disease. So for the first time, it was kind of defined the features and consequence of kidney disease at the time. That's why it's also called Bright's disease. So next slide, please. But the game changer of the kidney disease actually happened very recently. So that's around 1999, 2000, when the International Consortium kind of tried to define CKD. So chronic kidney disease has been redefined in the new millennium as any alteration of kidney morphology, function, or blood or urine composition lasting for at least 3 months. So that is the minimum criteria. So any of these changes should persist for more than 3 months. So this broad definition also encompasses diseases or conditions basically associated with normal kidney function also. Suppose if you have someone with a kidney with a scarring, or maybe an absent kidney, or a cystic kidney, for example, technically, you can basically call it as a chronic kidney disease, although the stage is different. Next slide, please. And this, I'm sure you're very much familiar with this diagram. So if you can see that on one side, y-axis, you probably find that EGFR categories, so from G1 to G5, and technically it is stage 1 to stage 5, and stage 3 is basically divided into 2, again 3A, B, and A and B. And on the right of your diagram, you actually find that albuminuria is added into the definition, so that you want A1, A2, A3 is basically normal or mildly increased, moderately increased, and severely increased. And based on the GFR and based on the albuminuria, the severity actually increases as far as CKD is concerned. Next slide, please. Okay, so when you look at common causes of chronic kidney disease, and you are very much familiar with these things in your general practice, so what do we find? High blood pressure, diabetes, two the most leading causes for kidney disease all over the world, including Australia. Well, obesity, which is again is a big problem. In our cohort, we have seen that about 52% of people are obese in our clinics, and about 83% are overweight. And then family history is important as far as kidney disease is concerned. Tobacco usage, smoking is a risk factor for chronic kidney disease. And old age, anything above 60 years, you are looking for CKD. And vascular problems, basically heart, cardiovascular, or cerebrovascular problems are invariably associated with some form of CKD. Next slide, please. All right. Can we launch the first question here, Nazia?
Yes, sure, Dr. Sree. Is it visible for everyone?
Yeah, I can see that.
Okay, we're getting answers now. All right, very good inclination towards uncontrolled diabetes and high blood pressure.
Yeah, I think so. That's
All right, around 63% people have answered.
That's nice, actually. In fact, I mean, that's true. Like uncontrolled diabetes, of course, is definitely the most important risk factor, which obviously, but it's very much linked to poor lifestyle choices also. Also, the only 4% said that. The uncontrolled diabetes is very much linked to poor lifestyle choices. And there is an element of genetic factors also, like diabetes is a very heterogeneous disease. So obviously, genetic factors do play, and high blood pressure, definitely. So in a way, answers are very much correct, but all are actually important. Can we share the results?
Oh, I did. 1 second.
You did already.
I'll share it
That's
again. Yes.
That's fine. That's fine.
I've shared it again. No problem.
Yeah. So we'll go on to the next slide then.
Yes.
Sorry, previous slide. So if you can close this question, go back to the previous slide. Yeah.
Yes.
Okay. Oh, yeah, that's fine.
Yeah. Okay.
Yeah, that's the slide. Yeah, that's about. Okay. So let's start, because diabetes being the very, very common condition causing kidney disease. And my practice is filled with all diabetic patients, actually, in fact. So what's the most important thing about when you talk about diabetes? All the primary care physicians, the endocrinologists, specialists, and everybody is focused on one particular number that's called 7. Okay. And maybe there's a reason why, because if you really go into multiple details, when I was very young, I was in grade 4 or 5, I watched this movie they call The Magnificent Seven. It's a lovely movie. And then if you really look into music, for example, there are what we call as Saptaswaras. So there are about 7 notes. And those people who are interested in much further spiritual kind of yogic life and other things, and you find that there are 7 chakras described. And for those of nature lovers, you find that there are 7 colors in the rainbow. So, hey, it looks that 7 is a very, very important number as far as life is concerned. Maybe so is the diabetes. Can we move on to the next slide, please? Yeah, so it's actually true in a sense. The UKPD study found out that the lowering HbA1c reduces the risk of diabetic complications. That's the UKPD study. And almost any diabetic endpoint, microvascular disease, myocardial infarction, retinopathy, and albumin. So if you look at that, as far as the reduction in HbA1c is concerned, per percent of decrease in HbA1c, you find the most important reduction in risk factors is microvascular. So it is retinopathy, nephropathy, and neuropathy. Whereas macrovascular, probably not to that extent, but it does happen. So yeah, 7 seems to be the number. Next slide, please. And we can actually, the number 7 actually came from, if you look at this slide, that is where it has come from. So when the HbA1c is less than 6, obviously they are non-diabetic. Between 6 to 7, we consider it to be a well-controlled diabetes. But you can start to see that anything above 7, when the HbA1c is started to go up, you find that all the related complications, the percentage is increasing. So I think that's where the number 7 has come from. Next slide, please. And so again, the UKPD study basically said the same thing, that glucose control is very important. However, I think there is a recent change in concept as far as diabetes control is concerned. We are not so much just focused on 7 and be happy, because you must have seen in primary care, very difficult to keep somebody just at 7. It frequently goes into 7.2, 7.3, 7.4, 8, 9, and then come back to 7. So what we are trying to see is, in most of this patient, especially in younger population, why don't you target for remission of diabetes rather than control of diabetes? In remission, in a way, can you safely bring down the HbA1c below 6.5 or close to 6 or below 6? See, the moment your HbA1c is less than 6, you're actually make them to be non-diabetic. So in diabetic patients, the focus is being shifting, especially in younger patients, to say, to keep them non-diabetic rather than be happy with a controlled diabetes. well, in elderly patient and with other complications, other things, probably with risk of hypoglycemia, it may not be possible in those set of group of people. But if you can, safely can do it, attempt to bring down it below 7, 6.5, close to 6. That's the way how it goes. And obviously in diabetes, the blood pressure control go hand in hand, because it's very clearly shown in diabetic people as well as elsewhere, blood pressure control is equally important in risk reduction. Next slide, please. And a 10 millimeters lower in systolic blood pressure actually leads to about 12% lower risk of MI, 19% lower risk of stroke, 15% lower risk of heart failure, and 17% risk of any diabetic related deaths. So it's obviously, it's very, very important that just not only focusing on the sugar control, but you must equally focus on the blood pressure control as well. Next slide, please. And when you talk about blood pressure control, diabetic or non-diabetic control, what comes to your mind? The preferred, the premium, the most prescribed medication in this particular group of patients is what we call as renin-angiotensin-aldosterone system blockade. So renin-angiotensin-aldosterone system basically works like that. You have an angiotensin, which by action of renin breaks down to angiotensin 1 by angiotensin converting enzyme, which gets to angiotensin 2, which acts on the AT1 angiotensin 1 receptors. And then you have all the features of that are possible there, like, like the glomerular capillary pressure, which leads to the cell injury. There is oxidative stress and leading to proteinuria, sodium and water retention, which in fact leads to hyperaldosteronism. So that's what's happening in these people. Next slide, please. So when you block this particular group of system, rather what we call as simply RAAS blockade, so we can block the hemodynamic factors like hypertension, sodium and water retention, and glomerular hyperfiltration. So it got, you have cardiac involvement and you have renal involvement, and you have benefits which are favorable in terms of cardiac disease as well as hypertension, and so is in diabetes disease. So there are multiple favorable factors by blocking these system. Next slide, please. And it's very, very, very clearly proven, multiple studies, long time back. This is a study in New England Journal in 1993. So it says that angiotensin converting enzyme inhibitors slow the progression of diabetic nephropathy. Very well established. Of course, they used captopril. After that, many of the cousins, enalapril, lisinopril, all these things, ramipril, were all used, and they're all found to be very, very useful. Next slide, please. So basically, the system RAAS, RAS system blockade in diabetic kidney disease. So if you look at a quick way, so what you're targeting is with albuminuria, you want to have the blood pressure less than 130/80. And if there's no albuminuria, less than 140/90, that's what it is. And so actually, you can use these medications to reduce the proteinuria and reduce the hyperfiltration in diabetes, even in the absence of hypertension. So you don't have to use it for hypertension patients. You can actually use it, right? And when you start using these medications, I'm sure you're all very familiar, there is an expected rise in serum creatinine and consequently decline in eGFR to about 25 to 30%. That is the action of the medications. It's not actually worsening of renal function. So you are aware of that and you should be mindful of that. And we also know that dual ACE-ARB blockade is not recommended. So please don't use a combination medicines like, for example, perindopril or telmisartan or valsartan and ramipril. Don't use two of them. Use either angiotensin converting inhibitors or angiotensin receptor blockers, but dual blockade is not recommended in practice. And remember, this blockade could be teratogenic. So be mindful in younger women with in that fertile age group. So always ask your patients that, is there a chance of considering they're becoming pregnant or want to become pregnant? So if such case, clearly be mindful and warn them that they have to discontinue these medications if they contemplate becoming pregnant or actually pregnant. So they should stop that. And one more important thing we should remember is what we call as sick day rules. So if any of your patients, for example, are unwell for any given reason, let's say diarrhea, dysentery, fever, pneumonia, whatever be the cause, they can safely discontinue these medications for a couple of days and restart when they're well. That's what is always we tell our patients. Sick day rule is very important. So when unwell, pause this medication, restart when they're okay. So that's the way how it is. And be careful about the potassium thing, because anything potassium over 5.5, 5.6 may be tolerable, but anything more than that, you just want to be very, very careful with this. Next slide, please. Okay, so when in early 90s, you know what I mean, when we get these medications, the whole nephrology community is very excited, saying that we got a miracle medication in terms of RAS blockade. We said, hey, with these medications, we are definitely going to slow the progression of kidney disease. So we went and told all the general practitioners, it went into national, international guidelines, and everybody kind of believed that, hey, these are the medications. And in fact, very, very found to be very useful that these medications to be used. And about 70-80% of all patients in Australia too, actually, are on these medications. So are they as useful as that or not? We are not sure. Before that, may I just quickly ask a very simple question? Nazia, can you just ask for a second question, please?
Sure, Dr. Sree. Yes, the question is online. We just wait for all the doctors to reply.
Yep. Perfect, as expected.
We have a very clear-cut, demarcated answer.
Absolutely, absolutely. In fact, plant-based diet is considered to be actually a preventive measure for progression of CKD. So that's a very good answer. Yep. Let's move on. We share the results and move.
Yes.
Yeah. Okay. Thank you. That's right. So the general practitioners on board with nephrologists, and we said, hey, these medications are useful. We started. But remember, when you actually started to use these medications, we found that there is a risk reduction about 30%, but there is a significant amount of patients who continue to progress towards chronic kidney disease and advanced CKD despite these medications. You are sure many of your patients who are on the maximum tolerable dose of these medications, they still continue to progress. And what do? You have done all your best things as far as possible, but they're still progressing. So at one stage, we felt, nephrologists, GPs, everybody basically felt a little kind of helpless situation. You tell the patients that I started this medication, you control your blood pressure, you control your blood sugar, healthy lifestyles, quit smoking, you've done everything. And then you said, hey, on these medications, then they're progressing. Then how do you actually prepare to prevent the progression? I mean, how do you prevent the progression? Can we launch to the next question, please?
Sure, Dr. Sree. Here?
Yes, please.
We're getting a very quick response.
Absolutely. And that's the perfect answer. I think that's what I'm looking for.
Yes.
Yeah, okay.
All right. We have almost 70% participants who have replied.
Yeah. I mean, if we can just answer one thing, high protein diet probably is not recommended. So that's probably is not yeah, in very rare circumstances, but generally high protein diet is not recommended in CKD. Normal diet, normal or low protein, but not high protein, definitely. Yeah, I'm very happy if patients are referred to specialists because my private practice flourishes if that is the case. But hey, the best answer would be that, yeah, regularly monitoring that. Yeah, you can share the.
I'll share the results.
All right, next slide, please. Okay, then what happened was around 2016, this study, what is called as a credence study, in fact, done in Australia, of course, the multicentral, but the main study focus was from Australia, done credence study. What they used is, you are familiar with what is this sodium glucose cotransporters inhibitors, which they are familiar with. They're empagliflozin, dapagliflozin, and it was actually initially the canagliflozin. These are the medications which came as what we call as diabetic medications. And they use this in type 2 diabetic patients and said, could it make any difference to the kidney outcomes? But still the thinking at the time was, by controlling the diabetic kidney disease, does it make any difference to the kidney disease? And indeed, looks like it actually made a difference, close to about 4,500 patients. And as you keep progressing that, you can see the two graphs are being separated there. And the hazard ratio P is very significant. And looks like there is about 30% reduction in progression of kidney disease. That is kind of an eye-opener. People looked at it and said, ooh, something is happening here. Next slide, please. And the reason for that is, and the reason for is that what we are looking is that there is an increasing recognition happened here that chronic kidney disease is basically not a single disease entity. So previously, what would have happened? Cardiologists would have treated patients with their heart failure, AF, ischemic heart disease, and myopathies. The nephrologist would have treated all their CKD patients, and endocrinologists would have treated their diabetes. And all of us, as specialists, would have bombarded the general practitioners with letters saying that you want this, you want this, I want this, I want this. But however, there is an increasing recognition now that all these three are integrated disease entities. They are not independently existing diseases. Next slide, please. So when this thing has come up, people said, hey, if a diabetic medication like an SGLT2 inhibitor, if it can be used in patients with chronic kidney disease, of course, diabetic kidney disease, or what is the effect? What is going to happen? And be mindful, all these patients are already on RAS inhibition, like they're on medications like angiotensin receptor blockers or AC inhibitors. So what's the hemodynamically what we are going to see? So if you can, this slide beautifully demonstrate the hemodynamic effects of using the combination of these medications. So it's a simple diagram. You can see that it's a glomerulus. It's got two arteries, arterioles technically. One is what we call as afferent arteriole, which brings blood into the glomerulus. Then you find an efferent arteriole, which takes away the blood from the glomerulus. And the glomerulus, the cup is filled with the capillaries. So normally what happens when you use like a perindopril or a lisinopril or enalapril or telmisartan, it is going to act on the efferent arteriole. And it actually dilates the efferent arteriole, relaxes the efferent arteriole. So there is decreased pressure in the glomeruli. So there is decreased intraglomerular hypertension. Because of that, the glomeruli works better. So that is the mechanism of action, how the ACE inhibitors or angiotensin blockers work. That's how it is. So when you start using SGLT, that is sodium glucose transport inhibition, what's going to happen is it is going to vasomodulate the afferent arteriole. It actually acts on the afferent arteriole and reduce the flow into the glomerulus and reduce the pressure in the glomerulus. Because it is very important in the context of diabetic kidney disease. So the diabetic kidney disease is divided into about 5 stages. In fact, the stage 1 is called hyperfiltration. There are only 2 conditions in humans where the eGFR actually goes beyond that 100% or 120. Is 2. One is pregnancy, which is a physiological. Second is diabetes. In patients with diabetes, initial stages of hyperfiltration, the eGFR can go up to 130, 140. And because of this hyperfiltration, there is a continuous damage to the glomeruli. Once the glomeruli are damaged, slowly the eGFR stops down, and then it down, and the stage of progression. So in diabetic disease, there is a hyperfiltration in the glomerulus. And by vasomodulation, there is decreased hyperfiltration and protection. So when you are combining both these medications, on one side, you are acting on the afferent arteriole by RAS blocker. On the one side, you are acting on the afferent arteriole by SGLT2 blocker. That's how brilliantly they work to protect the glomeruli. Next slide, please. So these are the inhibition in chronic kidney disease as well as in the cardiovascular disease in diabetic patients. What you're going to see is you have natriuresis because the sodium and glucose receptors are predominantly located in the proximal tubule. When they are blocked, lot of glucose and lot of sodium is delivered to the distal tubule and delivered and wasted in the urine. So there is natriuresis, there is diuresis, and when there is too much of sodium is delivered to the distal tubule actually send in a signal to the afferent arteriole to reduce the blood flow. That is what we typically call as tubuloglomerular feedback. So that is restored there. And of course, you have glucosuria. You know that you find a lot of glucose in the urine when you use these medications. As far as there could be reduced blood pressure there. And cardiovascular-wise, there is reduced left ventricular wall stress, improved oxygen delivery there, and reduced oxidative stress there. So you can see that there are multiple benefits as far as diabetes, as far as kidney, and as far as heart is concerned. Next slide, please. Okay, now the question has come. Many GPs very commonly ask this question to us, saying that, hey, yep, these medications have come. We are using this as a diabetic medication. Now you are asking us to use it in CKD, asking us to use this medication in heart failure. Hey, what could be the safety profile of these medications? So diabetic ketoacidosis was a major concern in patients, but actually not anymore. We really don't see it too frequently. However, just remember that diabetic ketoacidosis can happen if patient is really unwell or patients go through a procedure. So as far as these medications are concerned, if they're going through a surgery or a major procedure, just stop the medication temporarily, hold back, right? Again, the sick day rule applies. If they're unwell, stop the medication, restart it when they're well. So that's an important thing. And then the question has come about the bladder cancer thing and the bone fractures. And most important as far as the kidney is concerned is the acute kidney injury. In fact, initially the FDA in US has put up a warning that these medications can cause acute kidney injury. Okay, I'll come to that in next slides. But the question of volume depletion, because there's too much of glucose that is lost in the urine, so there's an osmotic diuresis. So that's where it is, volume depletion. So ask your patients to compensate for the fluid loss. Hypoglycemia is not a problem. Urinary tract infections, not a problem. In my practice, haven't seen excessive urinary infections. I mean, I've seen many patients and maybe a couple of patients had vaginal thrush. So it can be treated. That's the only thing. So as such, the safety concerns which have come up with these medications are largely addressed. And they're very safe medications. Next slide, please. But what's most important thing you should remember, everybody should remember that, as happens with AC inhibitors, when you start these medications, there is dip in EGFR, as you can see here. Like you can see that thing here. So up to about 5 to 7 ml of EGFR can be dipped. So when you initiate these medications first in any patient, there is what we call as EGFR dip. This is not acute kidney injury as was thought initially. So then what happens, as you can see that, so that is placebo where the EGFR is maintained, and that is SGLT inhibition where EGFR is dipped. But actually you can see that as they move at about 52 weeks, you can see that both of them get equalized. And in case of patients with placebo, the EGFR continues to go down. Whereas in patients with SGLT2 inhibition, you can see that it is stabilized and continues there. So that is the most important point to remember. So in patients, please don't expect your patients, don't tell your patients that they're going to get into renal failure. There is an expected drop of EGFR that is normal. That is how it acts. And it takes a while before it gets to the level of that normalization. And in fact, the question has come as how quickly we should check EGFR in these patients after initiation. I suggest in regular routine patients, you don't have to check it frequently. In patients with complicated medications, like they are on diuretics, they are on spironolactone, Lasix, Entresto, and other medications, you may want to check it in about 2 to 3 weeks, but expect the dip. Don't worry, if it is dropped, it is the action of the medication. You don't have to stop the medication unless it is very exaggerated drop. In some patients, there could be more than the 30% dip, especially in patients, complicated patients like cardiovascular patients with heart failure. Even then, please don't stop this medication. What you have to look for is there any cause why it has dipped more than what is expected? So if you want to adjust the diuretics, for example, reduce the dose of diuretics, maybe spironolactone 25 to 12.5, Lasix 80 BD to 80 once a day kind of thing, adjust the diuretic. Or just check if the patient is unwell concurrently, an infection, they were taking some antibiotics, or maybe somebody using non-steroidal antibiotics, like Brufen, Nurofen kind of thing. So just be mindful to rule out any other cause for this dip other than the normal expected. So try to keep the patient. There are, of course, few patients where you think that there's too much of EGFR dip and you may want to discontinue this. Most of the patients can be maintained on these medications. Next slide, please. This is the reason why people have done studies in terms of SGLT2 inhibitions and acute kidney injury. And all of them after so much of 15 months. And there's one study which is called 52 months follow-up. In fact, what has been found out is that the SGLT2 inhibitors actually have a protective action for acute kidney injury. In fact, they are beneficial for acute kidney injury rather than causing acute kidney. Next slide, please. As you can see that many of these studies, basically they showed that not associated with AKA at all when compared to other diabetic medications also. Next slide, please. And so the meta-analysis, which is published in the CJAN, basically suggested that there is no increase in acute kidney injury. And when compared to other diabetic medications, actually there is reduced chance of acute kidney injury compared to other medications. So that concern is out now, and we don't have to worry about it. Next slide, please. Okay, so should we just ask for the next question, Nazir?
Sure, Dr. Sree. I've launched the poll. We've got a couple of answers.
Yeah, sure.
A very good inclination towards all of the above.
That's true. Okay. So I think high blood pressure probably is not a major concern. Volume depletion, yes, but I addressed that. Volume depletion becomes more important in patients with other medications like diuretic or spironolactone and other things, and people who doesn't drink much of water or who are working in hot conditions, other things. In general, volume depletion is not a problem and which easily can be compensated. Low blood sugar levels are also, yes, it can occur, but not very common. In non-diabetic CKD patients, doesn't happen at all, so you don't have to worry about it. Similarly, you don't have to worry about diabetic ketoacidosis or ketoacidosis in CKD patients at all. Absolutely no worry at all. And in fact, below EGFR of 45, these medications are not effective for diabetes anyway. So you're not worrying about low blood sugar. Yep, thank you. All right, so now the question has actually come. When we found that these studies have come up and saying that SGLT2 inhibitors and chronic kidney disease, can these solve the unmet therapeutic need? See, when I told you in the previous slides, there is a significant number of patients progress despite all the measures which you have taken previously. And it is looking like now with the SGLT2 inhibitors, there is a delayed progression of chronic kidney disease, be it diabetic or non-diabetic. I'll show you in the next slides how good it is. And there is a definite reduction in cardiovascular events. So it looks like most of the guidelines are already coming in now. It extended to the whole chronic kidney disease population as a standard therapy. Next slide, please. Okay, why that conclusion has come? Look at these studies. The dapagliflozin study, basically the DECLARE study, which is about 17,000 patients. DAPA-CKD study, 4,300 patients, and the heart failure is 4,700. All these studies basically have shown there is significant risk reduction. So they're looking at cardiovascular deaths or major cardiovascular events and sustained decline in EGFR more than 50%, or end-stage kidney disease or death, or a renal or a cardiovascular disease. So they're looking at these endpoints, hardcore endpoints. Next slide, please. And what they found is there is basically a 17% risk, 17% risk reduction with cardiovascular death. And most important thing is the hospitalization for heart failure. I have seen many patients who actually get admitted to hospitals with heart failure. That's where the progression of chronic kidney disease, CKD, occurs. The EGFR further falls because of escalation of diuretic therapy. So that's important. But the DAPA-CKD study is actually absolutely a big change as far as our practice is concerned. It showed 39% risk reduction in progression of chronic kidney disease, just with 10 milligrams of dapagliflozin. Next slide, please. And the study, what it showed equal risk reduction in diabetic CKD as well as non-diabetic CKD. So that's the most important thing. So this is not simply a diabetic medication anymore. This has become a medication for diabetes, for CKD, and for cardiovascular conditions. Similarly, the empagliflozin, they have done a study too. So, and if you look at DAPA-CKD, they have taken patients from EGFR of 25 to 75 with significant proteinuria. So that's average ACR is around 900. So that is the group. So it felt that this is a high risk group. So the risk reduction happened because the group is high risk. So the EMPA-CKD study went a little ahead. Basically, they have taken EGFR from 20 to 90. So all those patients who are considered to be normal renal functions, and their average urine ACR is around 300, not 900. So those people with what we call as microalbuminuria kind of. Again, next slide, please. This study also showed significant reduction, 29% reduction in progression of kidney disease. In fact, the study was stopped early because the outcome is so good. So what happened now? With these DAPA-CKD and the EMPA-CKD trial, it's absolutely became very, very clear to all the physicians and specialists that these are becoming the drugs which are to be kind of routinely used in chronic kidney disease to prevent the progression. Next slide, please. Okay, so at this stage, can we go for the next question, please, Nazi?
Yes, Dr. Sree, it's launched and we can see the results live as well. We'll wait everyone to respond to that. Looks like option D is taking little dominance.
Mm-hmm. Yep, of course. So I think probably the message is getting in there.
Mm-hmm.
All right. Okay. Out quickly for these things. So as I said, hypoglycemia is not a big concern because we are not using this medication as a diabetic medication in CKD. And you don't need to adjust the dose. It is just 10 milligrams. irrespective of the EGFR. So whether EGFR is 70 or EGFR 30, EGFR is 45, the dose is 10 milligram dosage as far as CKD is concerned. And yeah, it should be prescribed to almost any eligible patient. And both the DAPA-CKD is actually PBS listed. I think EMPA-CKD will also come in. The dapagliflozin is now PBS listed for both diabetic as well as non-diabetic CKD. Okay, so I've shown this picture diagram before. Now, if you look at this diagram with respect to the three trials, the CREDENCE trial and the DAPA-CKD and the EMPA-CKD, as you can see, CREDENCE trial is basically limited to that particular group. So they are highly targeted patients, diabetic patients with low EGFR, with significant amount of proteinuria. So what the DAPA-CKD did, that the purple color there, it extended the EGFR criteria and it reduced the proteinuria criteria to an extent and said, hey, is it useful? And they found it's useful. So the EMPA-CKD study, that black dotted lines, went further ahead into saying that they went EGFR as low as 20 and included all the patients up to 90. So any patients with microalbuminuria included. So what's happening is, if you can see this slide, this is a very important slide. Previously, all the nephrologists, all the practitioners were only focused on these red areas. The last two are the G4, stage 4 CKD, stage 5 CKD, with significant albuminuria, that's A3, and saying that these are the people we are interested because they are the people who are going on to dialysis. But the focus has been completely shifted now. No nephrologist is worried about patients who are going on to dialysis, because if you take 100 patients in your practice, probably about 8 to 10 patients go on to dialysis. 90% of patients live with you and die with you. Okay, so the focus has been shifted from 10 to 90. So the 90% of people are all in this particular group. And what we want to do is to prevent the progression of kidney disease, not that they become dialysis dependent, but to prevent cardiovascular complications. That is the most important thing, because majority of kidney disease patients die with cardiovascular complications. So that is what we want to do. That is the reason why we want to prevent the progression of CKD. Next slide, please. Okay, so we did the RAS inhibition, the renal study and the IDNT study said, yes, we should, we have done it. We did the SGLT2 inhibitions. We said CREDENCE said, dapagliflozin, DAPA-CKD said, EMPA-CKD said, we are using it. And are we saying that is it the end of the game? Are we happy now? Wash our hands, clap, and then say that, hey, now we achieved anything. Or is there something else which we need to do in these patients? Next slide, please. Can we have next slide? Yep. So when you look at these three conditions, the diabetes, heart, and the kidney, it is what's happening is we know that hemodynamic component, that is the blood pressure, intraglomerular hypertension, and the GFR, we know that. And we talked about the glycemic control, how the high sugar affects to lead to glomerular sclerosis and vascular damage. But the third component in these two is what we call as inflammation, which ultimately lead to fibrosis. So when there is inflammation and when there is fibrosis, you can't reverse the process. And that is progression. And once this fibrotic stage happens, be it in heart, be it in kidney, you can't reverse it. Whatever medication you use it, they're going to go progressively downwards. So should we target that also? That is the next question that's coming. Slide, please. Next slide. Okay, so that where the evidence came from is from this a trial called RAILS trial, which was kind of published around 2000. What they noticed is that when you use spironolactone in patients with heart failure, it is, yes, we know that it's used in heart failure patients, it's useful, but they also found out that there is kind of reduction in multiple markers for fibrosis. So when they checked the blood for that and checked it and said that there are a lot of markers for fibrosis have been reduced, suggesting that this mineralocorticoid antagonists, can they reduce fibrosis? That is the question. And it looks like Yes, they can. Next slide, please. So there are three current and emerging MRAs. Spironolactone, you're all familiar with. Eplerenone, you have used it. And finerenone is the one which is coming up as a new medication, which is highly specific medication. Next slide, please. So as I said, the mineralocorticoid that antagonists are divided into steroidal and non-steroidal. The steroidal ones are the ones which has these side effects like gynecomastia and other things. That is typically come as the spironolactone and eplerenone. Whereas the non-steroidal, the finerenone, doesn't have that third generation one. It is highly potent, highly selective, and it's a much more potent one than the accelerates the degeneration process very quickly there. So the side effects are still less. Hyperkalemia is still an issue with all these medications, but you do not have the other steroidal factors like gynecomastia and androgen antagonism and other things. Next slide, please. So finerenone is being used in diabetic patients and the CKD patients. So if you look at the renal study in long time back using losartan, about 1,500 patients. IDNT study was 1,700 patients. Credence was 4,400 patients. Whereas the finerenone, there are two studies which have just been published in 2022, late 22, which is called the Fideldo study and the Figaro study. Both of them put together, you have more than 11,000 patients there. Next slide, please. Yeah, so the finerenone and the CKD. So the question has come, does using this finerenone slow the progress of CKD and reduce cardiovascular mortality in patients with type 2 diabetes? And used about 5,600 patients, and the answer is yes. So there is a 13% reduction in risk reduction in cardiovascular mortality and about 17% risk reduction in progression of CKD. So in patients with CKD and type 2 diabetes, treatment with finerenone resulted in lower risk of CKD progression and cardiovascular event than placebo. It's been proven, that's been published. Yep, next slide, please. So looking at this thing, finerenone hasn't come into Australia, hasn't been accepted by the TGA, doesn't come into the PBS. It will come soon because of the way it is. So when you actually look at the CKD timeline, in the very early 90s, we focused on high blood pressure. So we said control the blood pressure. But then in 1990s to early 2000, we have done these studies which showed that AC inhibitors and angiotensin receptor blockers are the fantastic medications. We should use that. And to the actually brilliance of all the general practitioners worldwide, especially in Australia, majority of these patients are on these medications. Guidelines are followed. But from 2000 till 2015, there is a big gap where we just did not do anything. We don't know what else to do. We have done our best. But early 2015, the EMPA-REG study has come using empagliflozin. Then you have the Credence study has come, the Canva study has come, and all these studies. So see from 2015 to 2022, how quickly these studies have come up, showing that these are SGLT2 inhibitors have come as a routine practice for management of chronic kidney disease. And I'm sure the finerenone is also going to come as one of the medications to be used in CKD patients. Next slide, please. Okay, should we ask next couple of 2-3 questions, Nazia?
Actually, Dr. Sree, they are posted in the form that will be shared later.
That's
so
fine.
it's not currently in the polls. Thank you.
So because of that, I actually suggest that all practitioners, basically what you need, first of all, you should know how many chronic kidney disease patients are in your practice, because they're big multi GP practices, you know, like you have 4, 5, 10 GPs in your practice. Each of would have seen thousands of patients. But first, most important thing is identify how many CKD patients are in your practice. Also identify at what stages of these patients are there, and identify patients with high risk to test for CKD. Identify patients with CKD to see, are we optimizing the management of these patients? So Kidney Health Australia actually did a pilot study in about 10 general practices. And what does now they're actually doing the audit which is open for all the practices across Australia. You can go to Kidney Health Australia website, register your interest, and participate in the clinical audit. So it is basically identifying the need, establishing the best practice guidelines for that, collect your data, and implement the change and monitor and sustain the improvement. So that's the way to move forward. And I encourage all of you to join, go to the website of Kidney Health Australia, look at their results, and register your practice for this clinical audit. Next slide, please. All right, thank you very much. And I hope you enjoyed my presentation and open for any questions and answers.
Thank you, Dr. Sree. That was really, really helpful and very informative. We'll just wait for everyone who is actually willing to share any questions. Do you have any queries regarding the topic? Please feel free to ask. And you can raise your hands if you'd like to speak to Dr. Sree directly. I can unmute you and we can have a little chat about this. All right. So far, we don't have any questions yet. Probably we asked questions or you launched all the polls. So we may have covered all the queries that was supposedly being asked. Other than that, I've already shared the link to the post-review performance questionnaire. Please feel free to just answer those. And I am going to share a proper link, a QR code, which you can scan. And if you're using your desktop, that is. And you can scan it for any further questionnaire. Okay, we do have a couple of questions. The first one is by Dr. Javira, and they ask, if we have to give NACID, what is the safest?
Okay, that's a wonderful question. It depends on the level of chronic kidney disease. If generally, my dictum is try to avoid NSAIDs if possible. But if you really want to give it for, maybe give it for the shortest duration possible, don't use it for long term. That's my suggestion. And I don't use it beyond 2 or 3 days. So there are patients who come for using for months and months and all. And if you really require a patient to use non-steroidal anti-inflammatory drugs, pain relief, please try to move on to the different kind of medications. But this obviously also depends on the level of eGFR. If somebody's GFR is, let's say, in the 60s or 70s, you're less worried than somebody's eGFR is in the 25 or 30. Okay.
The next one is, if the eGFR drops more than 25% after AC inhibitor, then should we do Doppler first or refer to a nephrologist?
Okay, if it drops more than 25%, just please immediately look for any associated reasons like volume depletion, or whether they've used non-steroidal anti-inflammatory drugs, or whether recently somebody started them on diuretics, which you are unaware, these people have gone somewhere. Just look for any of these things. If they are non-existent and a repeat renal function again, and if it is consistently dropped beyond that, suggest to do the Doppler first before referring to the nephrologist.
The next is, does DASH diet help with CKD?
Yes, DASH diet is recommended for CKD, but just be mindful that the DASH diet may have higher protein component and you are worried about the potassium component. So early stages of CKD, yes, probably towards later of CKD, you just want to be careful with the diet.
The last question right now, which is present, is will there be any role for angiotensin receptor neprilysin inhibitor, ARNI, in CKD, given its role in heart failure and the connection between heart failure and CKD?
Thank you very much. That's a wonderful question. Lot of patients are being put on ARNI now, and we co-share a lot of patients. And cardiologists are worried and nephrologists are worried whether there's further drop in renal function. And they are very useful medications. Remember that if heart failure improves, kidney disease gets stabilized. That is the most important thing. So all these medications which can actually stabilize a patient with heart failure is helpful for kidney disease. But as such, there are studies, a lot of studies which reported that these medications actually prevent the progression of chronic kidney disease. At this stage, the indication is still to use in heart failure, not as a CKD medication. At this stage, what may come up in future.
Right. Thank you for that, Dr. Sree. Also, there's another question. Should we start? When should we start screen ATSI for CKD?
Thank you. That's a very important question. And I used to work with a lot of ATSI patients in Sherbrooke when I worked there. So early, if you have the guidelines from wherever it is, the GP practice guidelines, early screening guidelines, especially in ATSI group, please be a bit more liberal. So check for urine ACR whenever you get an opportunistic thing, because the urine protein in this particular population is not all from diabetes. They have excessive streptococcal infections. So the GNs there and recurrent urinary tract infections and the ongoing damage there, use of a lot of non-steroidal anti-inflammatory drugs. So please, at an available opportunity, take the whole population come as a risk factor for chronic kidney disease. So when you have a patient with this particular population, check for CKD active as early as possible.
Yeah, everyone is thanking you. And to answer your question, Dr. Sana, yes, we will have the webinar recording. I will share that with the certificates like the previous neurology one. It will be one single recording and that will be shared with you. So you can let us know. Are there any further questions from any doctor?
Something happened in the chat. No questions in the chat there. Okay.
No questions yet, because we've actually cleaned up whichever was answered is under the answered portion.
Yeah.
So all good. Is there anything else that would need to be addressed? Thank you so much, everyone.
That's wonderful. I
All
really
right.
appreciate their interest. Yeah, really. Yeah, it's a good audience, very interactive. So thank you very much, everyone. But hey, if you have further any questions, please send it to me. I'm happy to interact, share with you. And I do a lot of the telecare online patients. So I see patients from all over Australia on telecare online. So if you really want to refer, no problem at all. We can do that too.
Absolutely. I'm just sharing an email address. So if you have any question or something which need to be addressed later, you can send it on gp@telecare.com.au and that can be addressed as soon as possible. Thank you so much. Dr. Sree, again, it's an honor for you to present for us. Thank you so much. It was a wonderful session and very interactive for all the audience as well. The polls, the questions, and hopefully it was very engaging for all of you all. So I will keep the QR code, or maybe we'll just stay online for a couple of more minutes. If there's any other question or any other query, please feel free to direct that and we'll be happy to answer. Thank you so much.
Excellent. Yeah, thanks,
Thank
everyone.
you for today. Thank you, Dr. Sree, once again. Once again, thank you, everyone. And if there's any other question, please feel free to direct it at gp@telecare.com.au. For referrals, you can go to our website directly, telecare.com.au. Thank you so much. And we'll see you in the next session. Thank you. Bye.